We were presented with a case of a newborn child who recently failed his hearing screening bilaterally. Upon further testing, we were able to conclude that this child has a profound hearing loss.
Upon reviewing the case history form and interviewing the family about medical histories and possible disabilities in other family members, we were informed that to their knowledge there has never been a case of deafness on either side of the family. So we suggested to them to check into genetic testing for a possible understanding as to where this hearing loss would have come from.
When we got the results back from the genetic testing, it concluded that there was a mutation in the connexin 26 gene. The connexin 26 gene is often involved with an autosomal dominant form of deafness, which means that one parent needs to be the carrier to pass it down to the child. The severity of this gene, of the hearing loss, can range from mild to profound, depending on the mutation. In this case, it was profound. Fortunately, this type of hearing loss is a non-progressive hearing loss, which means that there are no vestibular abnormalities. There is a hypothesis that the connexin 26 protein is essential for high concentration of potassium in the endolymph of the inner ear. We then explained to the family that sound is stimulated through the ossicular chain, which is caused by vibrations in the endolymph. Potassium enters the hair cells through these vibrations, and the vibrations are then converted into neural signals. The connexin 26 protein is present in all cell types throughout the cochlea, which means that it's very likely that this protein is involved with potassium recycling in the cochlea. Mutations of this gene can apply in any case, whether it is children that has no previous history of deafness or children that are born to parents with hearing. In order to provide more information and support to the family, I suggested that they come in for genetic counseling. I would like to be able to provide them any information about their hearing loss of their child and the possibility of it being passed down to another child, as well as I want to be sure that I can answer any sort of question that they need answered. I finished up by telling the parents that their child would be a great candidate for a cochlear implant since his hearing loss is bilaterally profound and the mutation of this gene does not affect
We
acoustic
had
nerve.
talked to the parents about early intervention since they were wanting the development of speech skills in their child when he gets older. So I explained to them that early intervention is crucial for this. Since he was identified early as a newborn, then it makes it easier for us to continue our steps. By 3 months, have him aided with a hearing aid. And so from there, we can go to a cochlear implant. So a hearing aid is recommended to keep the pathways on both sides of the brain stimulated before we can do a cochlear implant. In order to be a cochlear implant candidate, you have to have hearing aids for 6 months as a trial basis, and if the hearing aids aren't amplifying the sound enough for the child, then we will go on with the cochlear implant. I would recommend bilateral amplification with hearing aids as well as a cochlear implant since he is profoundly deaf. The reason why I would do bilateral amplification is because it will stimulate both ears, which will eliminate the head shadow effect, and it helps the child localize where the sound is coming from. Now with the cochlear implant, it will require surgery to implant the electrode array inside the baby, and then that will stimulate the auditory nerve fibers. If the cochlear implant is decided upon, the child will have to enroll into oral rehab program in order to work on his addition and his language skills. Also, there's new cochlear implants that are waterproof, so this is great for your child to get language whenever you're doing bath time, as well as in the pool with other friends and other children he can hear. I wanted to give facts about the cochlear implant to the parents because I know that they want to keep their son in the deaf community as well as in the hearing world by learning speech skills. And I feel like with a cochlear implant, he will best learn speech skills than with just a hearing aid alone.
There were 3 main modes of communication that we wanted to introduce to the parents for them to consider. And the first one was total communication, which would allow their child to learn all the different types of communication. They would study oral, manual, and oral forms of communication. So they would learn English as their first language and then learn ASL later on. And the idea behind this is that the studying of all the forms of communication not only help them communicate with the hearing world more effectively, but also increase their reading and writing skills. And then we also told them about the bye-bye approach, which would allow the child to have fluency in 2 natural languages. So in this case, ASL and English. And the way that this works is that they teach ASL before English because it's believed that ASL is easier learned as a first language and then you can learn English later on. And there are studies to indicate that becoming fluent in ASL will allow children to become better readers. So this would be preferred if they're really worried about their child's reading and writing skills. And the last one that we talked about was the auditory oral approach. And this supports early intervention, so it's ideal for babies and young children. And in this case, it would work well. There's lots of parental involvement, which is good, and they have to interact with qualified professionals. And there's also good technology for auditory input, so this would work with an aid or with the cochlear. So in learning this approach, the child would focus more on listening and lip reading than actual sign language, and it does encourage success in a variety of educational settings. We went ahead and introduced educational settings to the parents just so that they could be considering them early on, and the first one would obviously be residential schooling. So this would basically be a private school where the child lived on the campus year-round, and they're specifically for deaf students, so he would be in touch with the deaf community. The classes are smaller, the teachers all sign, and their peers are all also deaf. The schools are most favorably viewed in the deaf community because they provide education and connection to the deaf culture, and many of them employ the bye-bye approach, but they are less popular and less frequent than they were 30 years ago. There's also the day school option, which is a public school that would accommodate deaf students who live at home. The employees are all highly qualified to work with deaf students, and their curriculum usually mimics that of residential schools, but they're typically only located in metropolitan areas. Then they could mainstream school, and there are a couple of options for this as well. First would be that of an itinerant teacher, meaning that the teachers travel from school to school serving many students. They would provide direct instruction to the child, and they would serve them in a pull-out capacity, meaning that they would take them out of their regular classroom. There's been a push for some schools to make the regular classroom friendlier, so that's also an option. They could, have an interpreter in their regular classroom so that they wouldn't have to be pulled away from their peers.
In conclusion, we wanted to be able to provide the information for the cause of the hearing loss, the available devices to help aid the child, the communication modes that they could teach to promote the speaking skills, as well as the options of schooling later on in his future. Because this information can be hard to process as a new parent, I wanted to be able to provide as much information, counseling, and support as possible as they go about making decisions for their child's future.
And